Talofa lava with a smile, bula banaka, maloe lele, kia orana, pagalofa lahi atu, namaste. Very warm Pacific greetings to you all. Hot, fiery Pacific greetings to you all. On the second day of Forum, the Commonwealth gave to me a people's forum shaping what will be. Do you guys remember that line? A people's forum shaping what will be. Could you repeat that after me? A people's forum shaping what will be. Okay, so I'll just sing the first line. On the second day of Forum, the Commonwealth gave to me a people's forum shaping what will be. Do we believe that? Do we really believe that? Otherwise we wouldn't be here, right? Yeah. And yesterday, just to give a brief overview of just a few lines, yesterday what I heard as a creative first and foremost, as a divinely made creative, was actually, we've got all the information we need. We've got all the information we need. And what do? We heard about the important role of optimism, that we need that optimism for resilience. And before I hand it over to my beautiful co-host, Terry, I want to leave you with the lines of poet Maya Angelou. And she said, "A bird doesn't sing because it has the answer. A bird sings because it has a song." Now, yesterday I heard all the answers, and I also heard a spirit of disillusionment. What's changed since Paris? What's changed since COP2, whatever? So my role here as a creative, and as we saw last night, all our roles here, is to help us find and sing and tune up our song. Because a bird doesn't sing because it has the answer. A bird sings because it has a song. So let's sing our song today, day 2. Welcome back, everyone, and welcome to the stage, the glorious Terry.
Thank you so much. Thank you. How is everyone? We're pretty quiet in here. Does everyone know the song? If you're happy and you know it, clap your hand. If you're happy and you know it, clap your hand. If you're happy and you know it and you really want to show it, if you're happy and you know it, clap your hand. Now, this is just for research purposes. Show of hands, those of us who had tea this morning. Tea? All right. Show of hands who had coffee this morning. Show of hands who had a beer or rum. Oh, I've got about 2 hands, don't worry about it. We consider this space to be a very safe one, and we do not judge. If you had one word to describe yesterday, and you can shout them out, one word to describe yesterday, what would that one word be? Amazing, awesome, did somebody say emotional? Exciting, insightful, informative, engaging. Any more words? Fun. You know how good it is to hear that sessions talking about the hardest topics in the world. You choose the word fun, it means Selena and I, they all owe us drinks later on. Now, ladies and gentlemen, thank you so very much for being here. We thank you so very much for the compliments and the positive feedback. And many of you said that yesterday was just over the moon, which means no pressure for Selena and I today. I just want to remind you, for those of you who have your booklets, if you turn on the back, you will see a QR code. You can scan that code and you can get a good idea of what your program looks like for the rest of the day. Lastly, we want to remind you that the Your Climate photography exhibition, on the outside, it closes off at about 2:30 today. So if you haven't had the opportunity to cast your vote, please go ahead and do so. Just before we dive in, I heard Selena speaking just about a takeaway from yesterday. And I consider myself an outsider, and my one word is enlightenment, because I learned a lot from you. We spoke about a lot of hard things, but here are soft things that stood out to me. Number one, shut up and listen. That stood out to me, and even though a panelist was speaking to the government, the leaders, to shut up and listen, I believe that we could learn something from that as well, by being able to listen actively to other members and other groups. Do we agree? Do we agree? Optimism was something fantastic. Do we complain that rose bushes have thorns, or do we rejoice that thorns have roses? It depends on how you look at it. Something else that stood out to me was inferiorization. We heard that word. That even as we go about our business, we try not to inferiorize other communities. So let us jump into day 2. Our very first session is titled, Putting People First, Health Justice for Those Most in Need. Our esteemed moderator, Dr. Justin Koonin, is a member of the UHC Movement's Political Advisory Panel and former co-chair of UHC 2030. He serves on WHO expert panels on health preparedness, HIV, viral hepatitis, and STIs. Nationally, he is president of ACON, Australia's largest organization supporting HIV prevention and the health of gender-diverse communities. We welcome our moderator, and we welcome this session, Putting People First, Health Justice for Those Most in Need. Please make him welcome.
Talofa with a big smile today. It's great to see all of you. So I'm from Australia, as you've heard, and in Australia, as my friend and colleague Steph Harvey did yesterday, it's customary for us to acknowledge the traditional owners, the Indigenous people in the lands wherever we meet, both in Australia but also here. So I want to pay my respects to Indigenous people all over the world and recognise that the wisdom that they have for us, which is so important in these times. I've seen all the wonderful Samoan fabric. Well, I brought my Australian fabric. This is from the centre of Australia. I'm going to do a little bit of a shout out. I'm one of 5 civil society governors of the Commonwealth Foundation, and the structure of the Commonwealth Foundation, its governance is such that these 5 civil society governors exist so that civil society has a direct input into the governing and the processes and the strategy of the foundation. So I want to give a shout out to my fellow governors. I've seen Helen Kezinwoha from Nigeria, Darian Nareen, who you've heard from already. There's Helen, thank you. Darian Nareen, who you've heard from speaking yesterday and will speak again this afternoon, from Trinidad and Tobago, Safat Ahmed from the Maldives, and Mario Gerardo from Malta, who unfortunately couldn't be with us today. One of our roles is to form part of the Content Design Committee, which developed the program for this Commonwealth People's Forum, alongside, of course, our Samoan colleagues from the Public Service Commission and from Songo, and, of course, thanks to the very hard-working Secretariat. So if you like the program for this Commonwealth People's Forum, you're welcome. If you don't like it, I don't know who you're talking about. So we're here today to talk about health equity. As you know, there are 3 pillars to the Commonwealth Foundation strategy: health equity, climate equity, and freedom of expression. And they're all deeply interlinked, and we're going to hear that. To set the platform, just as with climate, we're not on track for the world's health goals. The latest data from WHO and the World Bank told us that a full 4.5 billion people, more than half the world's population, do not have access to essential health services. And 2 billion people are pushed into catastrophic health expenditure to pay for health services. The situation is not that different in the Commonwealth. In low-income members of the Commonwealth, 60% of people living in rural areas do not have access to primary health care. 70% of deaths are attributable to NCDs, and many of those are preventable. We all know some version of the problems, but the question, as so many people have said already, and it's really important, is what are we going to do about it? It's no use us all turning up to complain. It's no use us just talking about it, but what are we actually going to do? And so that's what this session is hopefully about, how we translate intention into action. So with that, let me invite up our esteemed panel. I'll do them one by one. I feel like these biographies do not do any justice to how wonderful these people are. I've had the opportunity to meet all of them over the past few days, but you'll hear from them directly. So our first panelist is Abi Begho. She's founder and program director of Lake Health and Wellbeing, an NGO in St Kitts and Nevis. She has over 15 years' experience leading projects on non-communicable diseases and women's health. She develops public health interventions, advocates for policy change, and builds alliances to combat NCDs. Please welcome Abi. Our next panelist is, and we're very pleased to have, a Samoan local, Faatino Utumapu, who's a disability rights advocate here in Samoa and a regional leader in implementing the Convention on the Rights of People with Disabilities. She serves on the Commonwealth Disabled People Forum Executive Committee and leads advocacy as Office Manager for Nuanua o Leo Alofa, supporting Samoa's disability associations. Please welcome Faatino. Next, we have Dr. Stellah Bosire, feminist, medical doctor, lawyer, researcher, and global health practitioner. She's the founding executive director of the Africa Centre for Health Systems and Gender Justice, which is dedicated to equitable healthcare and gender justice in Africa. Stellah's work focuses on advancing health equity and gender justice, particularly for women, girls, and marginalised populations. She's currently the chairperson of Amnesty International Kenya and also serves on the board of Civicus Alliance. Please welcome Dr. Stellah. And finally, someone we've met already, but welcome back, Sir Collin Tukuitonga, new and born New Zealand doctor, public health expert, and equity advocate. Sir Collin was knighted in 2022 and has held prominent roles, including as Director General of the Pacific Community and as a WHO Commissioner. He's currently Associate Dean at the University of Auckland, advocating for Pacifica health equity. Please welcome Collin. So I don't want to be standing here at a lectern. I'm going to come and sit with everyone. Is this on? Good. So to start us off, I'm going to ask all of the panelists the same question, and then we'll delve into some specifics. But to get us moving, and I'll start with you, Abi, how would you define health justice in the context of the Commonwealth and its diverse populations?
All righty. Well, good morning, everyone. It's such a pleasure to be here today. So I want to thank the Commonwealth Foundation for the opportunity to be on this panel. Also thank the Samoan people as well for the very warm welcome. So in terms of health justice, I think we all can appreciate what this is. It is the ensuring that everybody has equitable access to health care, health resources, health information, the ability to participate in healthy behaviors, and opportunities to achieve good health, regardless of your age, your gender, your disability, your social and economic or geographical background. And I think in the context of the of the Commonwealth, we have to think of health justice as restorative health justice. We have to think about how can we address the historic and systemic root causes of health inequalities and ensure really that we can decolonize our health systems and make them fit for purpose for the persons that live in the Commonwealth. And we also need to ensure that we can restore and repair and heal our people. But from an NGO perspective, we have to stand up when we see health inequalities and address these. We have to advocate for policies that protect our people. We have to advocate for policies that protect our shores from the importation of unhealthy commodities. So from that point of view, that is how I see health justice.
Amazing. Same question, Faatino. What does health justice mean to you?
Well, as a person with a disability, I believe that health justice is about a shift of paradigm. A shift of paradigm meaning seeing persons with disabilities as persons with rights, as opposed to the old days where we see persons with disabilities as persons who are sick or persons who are handicapped or persons who do not hold any rights. So it's about seeing persons as for who they are as opposed to what they have. And it is about seeking full and informed consent whenever we interact with people of diverse abilities. And it is also about recognizing that regardless of what people have, they still have rights, and those rights have to be recognized. Lastly but not the least, I believe it is also about recognizing that disability is part of human diversity. So it is part of us, and we cannot ignore it, or we cannot say that we have to be fixed in order to communicate normally with society.
Amazing. Stellah.
Yeah, so I'll not belabor the same points my colleagues have said, but I want to introduce a different concept of health justice, and it's addressing the social determinants of health. A lot of the times, by the time you come to see me as a doctor, I'm usually at the end of that spectrum. And so you have to look at your environment around you. How does your housing situation look like? What does the food security situation look like? How the issues around gender-based violence look like? How our laws, systemic laws, have been entrenched to be able to disenfranchise communities that are marginalized look like? How is it that we can shift some of these systemic issues, for example, around communities that are within rural areas who do not have access to information, do not have the infrastructure? How do we think about them? How do we think about the last mile child who have 0 dose in vaccination, beyond just saying we have the vaccine? How do we get the medicine to the people at the end of that spectrum? I think for me that's very critical. Recognizing the urban building, the urban development, recognizing that the transport infrastructure has a huge determination around how women access antenatal care, around how children are able to access childhood vaccination. It's very critical for us to think about our environment, and even the conditions that we're witnessing right now around climate crisis. It's not just an issue about the environment, it's a shift that we're witnessing around the changes in patterns of diseases. How then do we incorporate the justice component of it to ensure that those mostly affected get prioritized? Thank you.
Collin.
Good morning, everyone, and thanks again to the Commonwealth for the invitation. I think about health justice in the word fairness. In pure, simple terms, being fair, being responsive. There's a confusion between equality and equity, and we struggle in New Zealand all the time with this stuff, and you hear all the rhetoric about it's not about ethnicity or disability or this, it's about need and everyone should be treated the same. Well, you can't actually, of course everyone is equal, but you know the phrase, people get confused. When we're talking about equity, it does mean that some groups in our society need more resources in order to get the care they need, the quality of support they need, and so on. In other words, I think there's a massive confusion between equality enshrined in the human rights legislation in New Zealand and equity. In my view, equity is about older people, disabled people, children, rural residents getting more of the health resource than people like me. Women often need more resources in order to meet their health needs. That's the thing that people get confused about, I think. But it does reflect, in my view, the situation we have in Commonwealth governments. Our political systems entrench this confusion, I think, about what it is that's needed, and that's why it's important that advocates like yourselves continue to speak up, speak out for those who are not able to be as articulate as you are about their needs.
Thank you, Sir Collin. Such different experiences from each of our four panellists, but really strong common threads around social determinants of health, around what equity really means, around health as a human right. Thank you for that introduction. We do have panellists of hugely diverse experience, so I'm now going to ask some particular questions relating to their specific experience. So I'm going to start with you, Faatino. And I'm interested in understanding what strategies you've used to ensure that the voices and the views of people in marginalised situations and communities in marginalised situations have been brought into policy and decision-making structures.
Thank you. Thank you. Well, before I respond to your question, I have to say that the beauty of being an advocate is that you have plenty of opportunities, and if you fail the back door, and I mean the front door, you go through the back door. If you fail the back door, you go through the side door. So, allow me to share with you briefly 3 of our strategies that we are using, and I will be speaking from the perspective of persons with disabilities. NOLA, which is the lead advocacy organization of persons with disabilities, is mandated to advocate for the rights of persons with disabilities and opportunities for inclusion. So to do that, we as an organization do multiple level awareness on the barriers to participation by various persons with disabilities, the added value of being there as part of conversations, the various ways in which communities need to interact with persons with diverse disabilities. For instance, our colleagues who are deaf, our colleagues who are blind, and our colleagues with intellectual and psychosocial disabilities, who are often hard to reach and who are often not engaged in conversations because of their disabilities and the lack of resources. At the national level, we use opportunities we have. For instance, we have a focal point, that is the Ministry of Women and Community Development. This ministry indeed has a connection with the community. So we use this connection to reach out to the various communities to ensure that whatever development is happening there, persons with disabilities and their voices are included. We use our other network, such as the International Human Rights, the National Human Rights Mechanism, to ensure that the rights of persons with disabilities are included in all mechanisms concerning the human rights of everyone. Considering that disaster and climate change is one of the priorities of the Pacific, let alone Samoa, we use the network we have as a member of the disaster advisory body, to make sure that persons with disabilities are included as part of national efforts, preparedness and response efforts. Then we match our priorities and our needs to what is available by our donor agencies. There we have resources, though it's very limited, but we have resources to support the work of the organization, reaching out to its partners and making sure that we are there, not to warm the seats in conversations, but we also we are there to empower our own persons with disabilities as part of their capacity building to speak and raise their concerns and priorities so that they are included in conversations. Thank you.
Thank you, and you've clearly been very effective at doing that. Terrific to have you on this panel. I'm going to turn to Sir Collin, and one of the topics that you're really passionate about is the intersection between climate change and health. And I'm interested to know what changes we can do now to make health systems, especially in small island developing states, more adaptive and responsive to the health impacts of climate change.
There's a very good WHO framework on building blocks for health systems. It is really helpful. It's got 6 or 7 blocks. I'll just pick out 2. One is on financing healthcare. It's an unfortunate reality, and at least in our region, that there's a significant use of out-of-pocket expenses, meaning people pay at the point of care. That's a problem. The problem is that people who often have high health needs don't have the money. It's a fundamental flaw in our system, and our governments really need to re-examine that, because it's women and families and low-income groups who then can't get care, and that's grossly unfair and unjust. So there are alternative models for financing healthcare that our governments in the Pacific have not explored adequately. There needs to be a more collective, less focus on the individual paying, but having us as a community and a collective paying for healthcare. You have no idea when disaster is going to strike you or your family or your friends. In other words, we need to take those risks, and we really should discourage use of out-of-pocket expenses for healthcare in our communities. The second is about the workforce. People, we constantly go on about shortage of doctors in our region. I know it's a global phenomenon. And there's an unhealthy preoccupation with doctors. I'm a doctor, by the way. I'm a fan of independent nurse practitioners with prescribing rights. The Cochrane reviews tell us that they achieve as good outcomes as other primary care practitioners at a fraction of the cost. Number 2, they don't migrate to greener pastures. They tend to stay home with families and communities. They tend to be women and, a whole lot of benefits. But yet our nursing schools continue to train traditional nursing options, doctors and so on. I think we need to be much more imaginative about additional categories of workers. The world is facing mostly chronic diseases, people living with diabetes and heart disease. It's not acute infectious diseases like it used to be. We need people, a different category of health worker to help us navigate and manage. They're just examples. Sorry, I have gone on a bit.
No, I think that's really important. I mean, when we're talking about universal health coverage, which you can think of as in some sense one of our umbrella health goals, there are two dimensions. It's service coverage, so what services are available, but also financial protection. And in many parts of the world, in fact globally, while service coverage has improved over the last, call it 20 years, financial protection is getting worse and people are being pushed into further and further catastrophic health expenditure, and I think that's really critical. So thank you for making that point. Let's turn to Abi. You've done a lot of work in local communities, and I'm interested in how we can empower local communities to be involved in the design and the implementation of culturally sensitive health interventions, which promote social justice and health equity and address the specific needs of the local communities. So.
Wonderful, great question. So I think really it starts with relationship building, so genuine relationship building with the local community. A lot of the times you'll find that consultants are shipped in, there's a whirlwind around them, they've got tight deadlines, they speak to persons living with disabilities for like 1 hour, and then they're like shipped back out in this big whirlwind. And they literally don't have the time and the space to understand a local situation. So what we've been able to do, we live in St. Kitts and Nevis, we understand our people. So we take the time to sit one-on-one with people living with non-communicable diseases and to understand their issues, understand the challenges that they're facing, understand the inequalities that they're facing, and then to take a very intersectional approach to identify the persons that are most at risk. So through that work, we're able to identify, for example, I'll just give a couple of examples, that persons living with NCDs are not a homogeneous population. So, for example, the most at-risk group that we have found is the young women who are single, young mothers who are living with an NCD. Very vulnerable because they're on their own, they don't have any support, rarely any support. They're looking after children, and then they're also managing their non-communicable disease. Other groups that we have found to be particularly vulnerable were older women living on their own, living with an NCD. We also have found that women who are living with chronic reproductive conditions, so fibroids, endometriosis, PCOS, tend to get marginalized, trivialized, ignored, all of the issues. And so they are also a vulnerable group. So we can only identify vulnerable groups and empower people if we go into the community and speak to them. And at the heart of all of that is to empower people to speak their truth. And the way that we do that is that we're compassionate and we listen and we're sensitive. Because as you can imagine, if you're living with a chronic health condition, which can be quite sensitive and stigmatizing, you're not always going to want to share your truth. So we try very hard to be compassionate. We try very hard to give people time to speak their truth as well. So I think that is very important. We take all of that information and we work with people, work with the community to develop interventions that we think will be very targeted. So, for example, we have a project called Empower, which aims to empower women living with non-communicable diseases. It is a capacity building project. We heard from women. Women said, my NCD is holding me back, it's preventing me from thriving, and so we've developed workshops around that. Now, the workshops don't focus on their NCD. It focuses on other things, the social determinants. We are empowering them to be entrepreneurs. We're empowering them to speak up for themselves and to self-advocate. We're empowering them around IT skills, all of the things that they need to empower themselves and also to get out of the situation of being bogged down by their non-communicable disease and everything else. Also, we try to see what we can do to engage young people and empower young people to get involved in the work that we're doing. So we have a youth health advocates program, so we've trained young people to go out there and advocate. And really what we've done is we've empowered them, we ask by training, but we've empowered them by saying, lead, go forth and conquer. And so what they have done is they've conceptualized campaigns aimed at advocating for healthy food policies. They've had meetings with our Attorney General. They've written to the Prime Minister. They've written to other ministers to really advocate on behalf of young people. They've also organized policy dialogues with policy leaders, bringing young people together. So that is the way that we try to empower people to get involved in developing interventions that suit their needs. We get into the community, we listen to people, we try to be compassionate, and then we empower them to also implement. So that's me.
I really like that focus on getting people to speak their truth, and hopefully that's what we're doing here as well. And from experience of the past few days, you're not shy, which is great. Dr. Stellah, you're both a medical doctor and a lawyer. I don't know how you have time to do both, but a lot of your work has been around legal justice. And I'd like to know, in the context of the Africa region, how existing legal frameworks hinder or help efforts to achieve health justice, and how can we surmount both the legal but also the cultural barriers to equitable healthcare?
Let me begin by saying, let me start with the positive, that the Commonwealth countries have really made some stride in terms of developing protection mechanisms embedded within legal systems, within their constitution, progressive constitutions like the Constitution of Kenya, the Constitution of South Africa, that are really, have really made a lot of strides. However, there are two components of laws. So there is the existence of a statute that is supposed to be protective, that is supposed to hold accountable, either from a duty bearer perspective, who mostly are the states, and the right holders, who are supposed to be the demanders of the rights. And so when you look at it, there's a disconnect, because it's one thing to have a law, it's another thing to be able to implement a law. I'll give you an example. I think half of the Commonwealth countries have legislations against gender-based violence. And that's a very progressive law, right? But until now, if you look at our statistics around gender-based violence, they're horrendous, right? If it's coming to physical violence, rape, defilement of children, we still have some of the most horrendous numbers. What does it say? It says that there has to be a shift around how do communities then start looking at these laws of protective mechanisms where they can access justice, but also there are preventive ways in which they can use the existing laws. The other laws that have really been constraining or have really been dragging is the laws around freedom of expression, around sexual and gender minority persons. Our Commonwealth, and this is a fact, is that we are still lagging behind. Most of our sovereign states still have criminalizing laws, which are laws that we inherited from the colonial masters. And so it's very interesting to see that when you look at it from a colonial perspective, is that those countries that colonized us have gone ahead to actually have more progressive laws, but we've been stuck. And they're being stuck at that particular point, particularly around penal code provisions in Uganda, in Nigeria, in Kenya. Ghana right now, there's a bill in court, and that actually criminalize same-sex relationship with punitive laws that attract life sentence. And so that's very problematic. The other day, we went into a campaign in the whole continent against the repealing of the FGM law in Gambia. Why would a whole parliament sit and state that we have to repeal this protective law that is supposed to safeguard our children? As a medical practitioner, the horrendous experiences I've had with women who've gone through FGMs during delivery and the complications to a point of death or lifetime disability is something that we don't talk about. And so to see how our systems, our legislative systems and our policymakers are becoming now a barrier to the progression that we're seeing, despite the fact that most of our Commonwealth states have signed into international conventions like the Universal Declaration of Human Rights, the Convention of Elimination of Discrimination Against Women, among other statutes, including the CRPD around the Convention of Protection of People with Disability. We have to be able to stand back and say we cannot be the Commonwealth nations that are regressing and not progressing.
I'm going to stay with you, Stellah, and we're moving into a section around specific case studies, so we can throw in some really concrete examples of what our panelists have done in their countries, and we've actually heard some of those already. So I'm going to ask each of the panelists to respond around a particular question around their work. My request is please keep the responses brief so that we can open then the floor up to questions and comments. But sticking with you, Stellah, I'm interested in the use of technology, telemedicine, mobile health. How can we leverage those technologies to improve access to healthcare, especially for women and especially in remote and underserved areas? So something relating to the work that you've done in your own country.
I think it's a fact, and it's a WHO fact, that it will take 50 to 100 years for all countries, particularly in low and middle income countries, to actually meet the need of a human resource for health. And so that means that we must become innovative and rethink ways in which we can actually make healthcare accessible. It's a technology. So I'll give you 3 examples from my organization that we've done. During the floods that have ravaged through Kenya recently, what we did, we used the USSD on the mobile phone that did not require internet to be able to remind women where they could actually access their contraceptions or the next point of vaccination for their children. A very simple, very low cost effective. And also build on that around referral for those who are pregnant, because there was a lot of displacement. The infrastructure that existed within those areas were also disrupted. And so finding means and ways of making that possible. The other model that we've also used, is an innovative model, is using women networks around table banking, what we call in Kenya and Uganda, chama. And so the issue around healthcare financing continues to be an issue that constrains our economy, you know. And so finding means and ways of helping women to have skills, entrepreneurial skills, but also to find ways of investing and saving part of that money using mobile phones, you know. M-Shari in Kenya, for example, using M-Pesa. And they save there to certain amounts that they can now be able to purchase care through social health insurance. Because if you tell them you have to pay, for example, $60 in a blank at a go, that's a lot of money. But if you give them means and ways that they can actually save within a prolonged period of time, and then what you do is you brokerage with the social health insurance or the private insurers, then it becomes very easy for them to purchase health care. Until we are able to address the out-of-pocket expenditure, as Collins has said, which in our states, most of our states, is about 20 to 30%. And that is catastrophic, because what it does, it already sends our people who are already living in poverty further into detrimental poverty. Thank you.
Thank you very much. So, Collin, so we heard yesterday from Darian that his grandmother's remedy did much better for COVID than all the pharmaceuticals that he was being plied with. One of your other interests is the relationship between traditional practices and Western medicine, and I'm interested in your thoughts and your practice in terms of how we can integrate Indigenous ways of healing with Western medicine.
Yeah, we had this discussion yesterday. I want to make 2 comments. One is, I'm not sure about the wisdom of this relentless drive to incorporate traditional medical health practices into conventional health service delivery. People seeking health care is a very personal experience, and they will go and find health care from whomsoever they feel comfortable with. And sometimes that's the traditional healers in the community. And as I say, why would we want to incorporate traditional practices into conventional service delivery models and make judgments about effectiveness based on conventional delivery models? In other words, I would just ask people to think again about whether we should be doing that. There's also a perception that if you go to seek traditional healing, it's a risky undertaking. I would just remind people that if you seek healthcare from a conventional doctor or healthcare practitioner in a conventional sense, you have 10% probability that something bad's going to happen to you. So I would just, I don't have an answer, Justin. I just ask people to reflect about what it is we're trying to do here. People will go and seek care from the village or community practitioner for their own reasons. We need to learn to work with those, regardless of whether we agree with it or not. So, sorry, to come back to the question, I don't have an answer. I'm just saying, let's think again about why we would do that and what's the purpose. Easy enough, of course, to incorporate in as part of the entire system, but it's really about what the overall purpose of doing that is, because you can, but let's not make judgments about the value of one set of practices based on the majority view. Sorry, that's probably not the answer you were looking for.
No, I think testing our assumptions is the best thing that we can possibly do here. So thank you. Please keep it coming. Faatino, you've obviously spent a lot of time working on health systems which are inclusive of people with disabilities and sensitive to the needs of people with disabilities. What do you think we need to do to create a health system that truly meets the needs of people living with disabilities? Are there some absolute musts that countries really need to do?
Well, from the perspective of an advocate for persons with disabilities, I believe the first thing to do is to match the huge disconnect between what's written on paper and what's available in terms of resources. The International Convention on the Rights of Persons with Disabilities, which has been signed or ratified already by most of the Commonwealth countries, Article 25 stipulates a lot of measures that governments need to do and community, from removing discriminatory provisions in legislations to embedding preconditions to inclusion into health systems. When I say preconditions to inclusion, I am actually referring to things like assistive devices, because quality healthcare systems is not going to be complete without the provision of assistive devices, rehabilitation programs for those who are in need, as well as training of health professions in the area of disability. As in the Pacific, qualifications such as physiotherapists are often limited, but those qualifications are of paramount to ensuring the quality health that we need for persons with disabilities. Translation of documents, plannings into meaningful results is also critical. Ensuring that procurement systems recognize the need for persons with disabilities to subsidize the procurement of equipment pertaining to improving their health status. Lastly, but not the least, I believe with all the plans, with all the legislations, I guess one good thing for the Commonwealth to do is to work with persons with disabilities and indeed resource the work of the organizations who are doing advocacy and promotion of quality health services, programs, legislations, to name a few.
Thank you. All important points, but I think particularly this issue of resourcing comes up and up again. You can't expect people to do the necessary work around inclusion unless they're resourced to do so. So thank you for highlighting that. And finally, I'll ask Abi a question, and I'm interested in this question of social participation, of the inclusion of communities and community-led organisations in national and subnational and local health planning processes with governments. How do we bring local communities into these processes to ensure that the programs that are designed meet the needs of the communities?
So I'll just touch on 3 points. So I think the first thing is building constructive relationships with policymakers. So at times I do find the relationship between civil society and policymakers a little bit dysfunctional. And so what we've tried to do is really change the dynamic between community-led organizations and the policymakers and the government, and really make that relationship a lot more constructive. So what we do is that we've taken our time to meet with different government ministries, understand what it is that they are looking for, looking at what their priorities are, and we've tried to align our work with them as well. That doesn't mean we don't challenge. We challenge them politely and respectfully when it's needed, and we raise issues when it's needed. So what we've been able to do is we've taken like a long game kind of approach. So we're going to develop that relationship. We're going to demonstrate the value that civil society has as it relates to supporting the work to improve public health outcomes. And that means showing that we can be a key partner. We can provide useful data that the Ministry of Health can use in terms of policy making. We can educate the public. We can implement public health interventions, and we can educate the public on health matters, so that really it makes it easier for the Ministry of Health in terms of the work that they're doing, because we are a constructive partner with them. So in essence, what we've tried to do is really be also a bridge between the ministry and the public. So as we speak to the public, we write the reports, we write some recommendations based on all the information that we've gathered, and we share that with the Ministry of Health so that they can use that in terms of their planning. So that's the first thing, is really just building constructive relationships with policymakers. The second thing is alliances, so civil society alliances. So what we've done in St. Kitts and Nevis, so we, Lake Health and Wellbeing, we are the conveners and of the St. Kitts and Nevis NCD Alliance. So we developed the St. Kitts and Nevis NCD Alliance, where we've brought civil society together so that we can amplify our voice around NCDs and advocate for NCD policies. So through that, we're bringing together NGOs and allowing them to connect directly with policymakers. But that's on the local level. So on the regional level, we're also a member of the Healthy Caribbean Coalition, which is a civil society alliance of over 80 organizations from across the Caribbean. The Healthy Caribbean Coalition is extremely effective at advocating for policy on the regional level and global level. And so in that way, we're also able to advocate and have a voice regionally amongst regional policymakers. Then on the global level, we're also a member of the Global NCD Alliance. So now that gives our NGOs in St. Kitts and Nevis the opportunity to connect with the policymaking process on a global level. So that's the second thing. The third and final thing is, one of the challenges that we have in St. Kitts and Nevis, and I think across the Caribbean, is really the hesitancy of policymakers to discuss policy and legislation in a public space. There seems to be this kind of discomfort. So what we've tried to do is be quite proactive, and we've actually created the space to have that dialogue in St. Kitts and Nevis. So for example, our young people have organized policy dialogues, which I think I mentioned before, between young people and policymakers to talk about sugar-sweetened beverage taxation, which is something that the policymakers were very uncomfortable discussing in a public space, and we got our young people to take the lead and have that discussion with policymakers in a public space. We have brought together civil society and policymakers, numerous events, workshops, webinars, various different things, bringing policymakers and civil society together to explore how we can work together constructively. We've also engaged lawyers, so the Bar Association, to sort of do some capacity building around what is their role in the prevention and control of NCDs. So that's around legislation. We've also done events with civil servants from across the spectrum to really engage in conversation around having a health in all policies approach. And then finally, what we've tried to do as well is bring the public along as well. So we've engaged the public. We have tried to be creative because, you know, policy is not exactly the most interesting topic in the world for the public. So we've tried to be very creative. So we've done things like animations, and we're very proud that one of our animations was shortlisted for the World Health Organization Health for All Film Festival. And that animation really spoke to it took an emotional look at the choices that we make around health issues. So we try to be creative. We have a creative jingle that engages the public, and people are singing it all over the place, and that helps us have a conversation with them about the health issue that we're talking about in the jingle. We're developing a computer game to try and engage young people around health issues as well. So we're trying to create, I'll wrap up. So we're trying to be creative in the way that we engage people in the policy discussions.
Thanks, Abi. It's really terrific to see how you're concretizing this issue and making it live on the ground, but also how you're connecting what's happening at the local level with what's happening regionally and globally. And perhaps if I could take my chair hat off just for 1 second and to give a little bit more of the global context. At this May's World Health Assembly, which is the board meeting of the World Health Organization, member states passed a really significant resolution on social participation, calling on countries to institutionalize processes for the inclusion and participation of civil society and communities in national, subnational health planning processes. So this is now a tool that you can go back home and say to your government, you've signed up to this, what are you going to do about it? And I think it's really important that members of the Commonwealth know about that. Something else that happens around the World Health Assembly is the Commonwealth Health Ministers meeting, because everyone's in Geneva anyway. And so I want to do a little bit of a shout out to the Commonwealth Foundation, Anne and her team, and I see our Chair of the Board of Governors, Ambassador Suda, is here as well. But the Commonwealth Foundation has really fought hard for the inclusion of civil society voices in the Commonwealth Health Ministers meeting, both in terms of the actual agenda of the meeting itself, but also through roundtables that we hold with Commonwealth senior officials. It is like prizing open a door, and they're kind of like these big, heavy, beautiful doors, but it's kind of hard work. But we're making really good progress. So I want to acknowledge what the Foundation is doing there. But we need your voices to continue to prize these heavy doors open, because let's face it, in many Commonwealth countries, civic space is not exactly enlarged, and we really need to work and sometimes to fight for it. So speaking of your voices, we're now going to move to a Q&A session. I'm going to stand up just so I can see you all. So this is the space, you know now, available for comments and questions. Please keep your comments and questions related to the topic of health justice, and please think really hard about how you can make your intervention brief so that we can get through as many as possible. I want this to be talofa with a smile. I do not want to do talofa without a smile. You don't want to see that. It might involve interpretive dancing or something, but I will if I need to. And I guess we have someone running with a microphone, yeah?
Talofa with a smile. I think the scientific evidence now...
And also introduce yourself.
That's right. Victor Burton and Talofa with a smile. I think, to keep it brief, the scientific evidence is fairly clear that the trait most associated with healthy longevity, both physical and mental, is optimism. And you've been marvellous in bringing each of the stories to bear. So my quick question to you and to each of the panellists is, what makes you optimistic for the health issues and solving the health issues in the Commonwealth?
That's a good question. Let's do a 30-second vox pop. What makes you optimistic?
The young people, oh wow, I think young people are just wonderful. They bring a freshness to our advocacy. I look young, but I'm not actually young, so I'm not the young person I'm speaking about. They bring a really fresh perspective to our advocacy. They're very passionate, they want to see change, and because we have such wonderful young people, I think our future is very bright, so I'm very optimistic about our young people.
Faatino.
I believe the limited opportunities to access and the fact that disability is now beginning to be recognized as not a business as usual make me optimistic.
I think for me, it's, when you look at the Commonwealth nations, we are at a point of, we've started growing, right? Even if you're making very small strides. In that growth, and with the inclusion of a very young demographic dividend, that gives us an opportunity to be able to shape the future of young people and the future of our countries.
Nuans are built that way. When you live on a rock, you have to be optimistic. Otherwise, it gets pretty tough.
And for me, it's all of you. It's all of you. There's so much energy in the people. So thank you. All right, there was some hands over here. Okay. Yep.
I can't stand up and hold a microphone at the same time, sorry. My name is Rhoda Garland. I'm the Commissioner for the Rights of Persons with Disability in Malta, but I'm here with the Commonwealth Disabled People's Forum. I just wanted to